Good afternoon, everyone, and welcome to our fourth ACA NY and LifePlan CCO NY provider webinar. Today's main topics are the CCO enrollment and service authorization processes. We will first begin our presentation by giving several timely updates, primarily related to the end of the public health emergency. We will leave room in between each topic for a brief Q&A, as we understand there's a lot of information being presented. We thank you for joining us and hope this information is informative and beneficial. I am Crystal Persida Sapienza, Director of Provider Relations for Brooklyn and Queens, and presenting with me today are Megan Porter, Director of Provider Relations for Metro and Staten Island, Kim Janes, VP of Care Management for Long Island, and Catherine Greif, VP of Care Management for the Capital Region. To ensure sound quality, everyone is currently muted, and we ask that you refrain from muting yourself. If you experience trouble with your audio, please send a message in the chat box and someone will assist. Questions are welcomed and encouraged. Feel free to submit your questions in the chat box throughout the presentation. Please note that today's presentation is being recorded. The recording and accompanying Q&A will be posted on both ACA-NY and LifePlan websites in the coming days. As noted in today's webinar, we will talk about some important updates. We will then go into our main presentation, which will discuss CCO enrollment, how the process differs for adults and children, and common challenges which may delay the process. We will also go into detail about service authorizations, where we will discuss the processes of initial authorization via the RSA form and authorization for services via the SARF form. We would first like to update our providers today on the unwinding of the PHE, network provider agreements, Medicaid recertifications, and DOH consents. Effective May 11th, 2023, the following flexibilities have ended: in-person face-to-face flexibilities, LCED annual redetermination extension, verbal or email approvals for life plans, timeframes for finalization of non-COVID related life plan changes, and the use of telehealth for life plan annual meetings. After May 11th, 2023, all care managers will be required to meet in person with their members unless the member elects to participate in telehealth services. All members, tiers 1 through 3, who choose the telehealth option must be in person for their annual life plan meeting and at least one other meeting 6 months following the annual. This may occur at the semi-annual review or another meeting of the member's choosing. The other 2 required quarterly in-person meetings may be conducted using the telehealth option. Tier 4 non-Willowbrook members must also have 2 additional meetings in person throughout the year, unless they choose fewer than monthly face-to-face meetings. Tier 4 non-Willowbrook members have the option to reduce the frequency of the in-person visits and the modalities in which they are conducted, meaning in-person versus telehealth. There are a total of 4 options for Tier 4 non-Willowbrook. Care managers are currently working with all of their members to provide them with the options to ensure informed decision-making. We can provide these options in the FAQ to follow. For Willowbrook class members, there are no changes to face-to-face requirements. The care manager must have a monthly in-person contact, and there are no telehealth options. At least one CMOR must be completed between now and November 11th, 2023. Members who are net new, meaning they are new to the CCO, must have an in-person face-to-face meeting within 60 days of enrollment. Their initial life plan meeting must be in person. For those who receive basic HCBS plan support and state paid care management, the face-to-face contacts for both life plan reviews must be in person. It is important to note that these are the minimum standards. The care manager can conduct additional in-person visits immediately if there is a health or safety concern, if the member's needs require in-person visits, or if the member's requests an in-person visit. I would like to take a moment to review the requirements for telehealth services. Telehealth must meet the person's needs, be effective, and cannot be the sole method of face-to-face communication. The care manager must alternate between telehealth and in-person meetings. If engaging remotely becomes ineffective, unsafe, or does not meet the person's needs, it must be discontinued. The care manager and the member must use both audio and video for the duration of the telehealth visit. Care managers can only use Microsoft Teams when conducting care management services via telehealth. For LifePlan CCO, both Microsoft Teams and the HIPAA-compliant platform of RingCentral can be used until June. However, the use of Microsoft Teams is encouraged, as once LifePlan stops using RingCentral, Microsoft Teams will be the only approved and available platform for care managers to conduct telehealth visits. Care managers are not permitted to use FaceTime, WhatsApp, Google Meet, or others for any reason because these platforms are not HIPAA compliant. Care managers are not permitted to join meetings that have been set up by a member or representative. As stated earlier, if the member is not able to participate using technology that supports audio and video, they will not be appropriate for telehealth services. However, the care manager can work with a member to support and educate them on how to use Microsoft Teams if they choose to receive some of their care management services via telehealth. The care manager must also ensure that the member has privacy during telehealth visits and meets all security standards set forth in HIPAA. The member should be in a private place so others cannot hear their discussion. The care manager reserves the right to stop telehealth visits if they believe that they cannot be conducted privately, safely, or effectively. Members who wish to receive telehealth visits must request the service. For members that request remote telehealth services, the care manager will create a LifePlan addendum, adding in a telehealth request statement in the Introducing Me narrative of the LifePlan. Reaffirmation of this choice must occur at each LifePlan meeting semi-annually. A summary of this reaffirmation must be noted within the IDT section of the LifePlan. Additionally, the original language added into the Introducing Me section cannot be removed. Members may choose to discontinue the use of telehealth meetings at any time. If a member representative chooses to return to in-person visitation, the care manager will take immediate action to amend the LifePlan using required language implemented by the CCOs. Although LCED extensions were part of the COVID-19 flexibilities, it is important to mention that ACA-NY and LifePlan CCO continue to follow our LCED redetermination policies during the PHE. In March 2023, ACA-NY's and LifePlan CCO's care management teams redetermined every member's LCED, regardless of when they were last completed. ACA-NY and LifePlan CCO have an 11th-month redetermination policy for LCEDs, so they will be redetermined again in February 2024. This helps to ensure that there is no lapse in the LCED, as it is a critical document for CCOs and providers. LCED annual redeterminations are uploaded to Choices and located under supporting documents. Going forward, the LCED will be attached to the annual LifePlan for distribution. The next CCO flexibility that has ended as of May 11th pertains to LifePlans. As we mentioned earlier, annual LifePlan meetings must be held in person and are no longer remote. The annual LifePlan date can no longer be extended. It must be completed by the end of the month in which the previous annual review was completed. After May 11th, care managers can no longer obtain verbal or email approval of the LifePlan. The care managers must finalize the LifePlan within 45 days and distribute it to providers for signature to acknowledge and agree to assigned services. The last part of the PHE unwinding that we will discuss today is the resumption of the Medicaid recertifications. It is important for our providers to understand this information, as we have members living in certified settings and even members living in the community who may come to you for guidance. Medicaid program easements began to be lifted as of April 1st, 2023. Non-SSI cases with authorization dates ending on June 30th, 2023 will undergo full review under pre-pandemic rules. This means that individuals must return their renewal and provide relevant documentation to continue their coverage. If the renewal is not completed and returned, their case may be closed. Cases that have authorization end dates through May 31st, 2023 have been extended for 1 year and will be renewed in 2024. The Medicaid Assistance Program expected that June 2023 renewals were mailed out in March or the beginning of April. Members with authorizations ending in later months will receive a separate mailing to alert them that they will need to renew their Medicaid when their case authorization expires. As you may know, the Medicaid allowable income and resource levels increased significantly for 2023. When an individual returns their renewal, their case will be rebudgeted according to 2023 standards. Excess income or spend down cases can be rebudgeted even if they are not due for renewal by submitting a request to the local Medicaid office with proof of an individual's current income. Please note that there are other flexibilities that will end on November 11th, 2023. This will be covered in more detail in future webinars and newsletters as the guidance may change. Over the last few months, service providers may have heard from the Directors of Provider Relations regarding network provider agreements. At ACA NY and LifePlan CCO, we value our relationships with our service providers and appreciate your commitment to our mutual members. One of our responsibilities to our members as a CCO is to connect with a broad network of providers beyond the partnerships we developed at the time of the transition. To help with this, the Directors of Provider Relations have contacted providers in their regions to request they complete a network provider agreement. The network provider agreement shows our efforts to develop a wide network to OPWDD. We want to emphasize that the agreement is not binding. All service providers are encouraged to join multiple CCO networks to maintain continuity of care for their members. If you have any questions about the network provider agreement, please contact the Director of Provider Relations for your region. Regional contact information can be found on the providers page of our websites. The Provider Relations Department would like to remind our providers of the importance of ensuring they are listed on the DOH consent forms. The Customer Service Center and Care Management Team are not able to release documentation to providers unless they are on the DOH consent form, or if the provider has a consent on file that lists ACA NY. This is to ensure that the member's privacy is protected. It is expected that the care manager will complete a new consent at the time of the annual LifePlan meetings. They will also update the consent anytime new services are added, and they will review the consent semi-annually thereafter. Please note that the guidance released by OPWDD regarding the unwinding of the PHE is very recent and changes may occur. The Provider Relations Department anticipates addressing any changes in future webinars and newsletters. Okay, so before we move on to discuss CCO enrollment processes, I would like to take a few minutes for questions pertaining to what we have discussed so far. Any questions that we don't have time for today will be answered in a Q&A document that will be posted on our websites.
Okay, thanks, Crystal. So let's get started with our Q&A. Everyone is a little quiet today so far. I do have our first question from Irene. Is a care manager not able to attend virtual meetings if held on another platform such as Zoom? I'm just going to call on one of our care management co-hosts. Let's see. Kathy, if you would mind helping us out with that question.
Sure thing. I'm sorry. Can you read the question back to me again?
Sure. Yep. If a care manager is not able to attend virtual meetings, if they, I'm sorry, let me rephrase. Is a care manager not able to attend virtual meetings if held on another platform such as Zoom? And I assume this is if the provider is sending the invite.
They may attend a meeting where they get an invitation from a provider. However, our care managers would not be able to share their screens during those meetings. So they are able to attend.
Okay, great. Thanks.
Sure.
Thanks, Kathy.
Yep.
Okay, so our next question is about the LCED from Sonia. The LCEDs that they currently have expire in the fall. and they do not see it in choices. So do they need to wait for the next updated LCED? So I just want to mention, if anybody is looking for an LCED in choices and it is not there, you're more than welcome to contact the customer service centers for ACA and for LifePlan. We're actually going to share their contact information later on in the presentation, but you can absolutely contact them, and as long as you're listed on that DOH consent form, they will send you a copy. Next question from Elisa. If the life plan, what do we do if the life plan meeting was held without the provider present? I'll ask again, Kathy or Kim.
I'm sorry, go ahead, Kim.
Okay, so generally speaking, the members of the IDT team should be included in life plan meetings. It's required that the member and the care manager are meeting together, but every effort should be made to include service providers as well. It's kind of hard to answer that without being super generalized.
In a broad sense, yeah.
Yeah.
If there are any specific concerns, you can always reach out to the Director of Provider Relations for your region, and we can, discuss with you and see what we can do to help. Okay, next question. Who is required to sign off on a life plan addendum when the care manager is adding the remote justification? Is it only the member and family, or does it have to be signed by the whole team? I believe the answer there is that it just has to be signed by the member and family.
That's correct.
Okay, thanks. Okay, next question. Will these slides be available after the presentation? Yes, we are going to post a recording and the Q&A document to our website in the next week or two. So we'll also post a PDF of the slide deck there. I have a question about network provider agreements from Andy. I haven't been contacted yet about signing the provider agreement. Is it the responsibility of the care manager? That's actually a provider relations initiative. That's not coming from the care manager. So if you have not heard from the Director of Provider Relations, if you'd like to leave your email in the chat, you could send it privately to one of the hosts. We can get back to you about that. The questions and answers are very helpful. This is coming from Evelyn. Will the Q&A be summarized and made available to today's attendees? Yes, we will have all of these questions. We'll write up a nice Q&A document for everyone, and we'll have that posted to the website. And I see a few people leaving their contact information in the chat, so thank you. We'll reach out to you, in the next few days to touch base and, make sure you're in contact with your Director of Provider Relations. I think that is our last question. Actually, nope. Here we go. So there's a question from Barbara about consents being on file, having trouble obtaining care management information for program members without the consent on file. Whose responsibility is it to be sure there is a consent on file? That is the care manager's responsibility to make sure that that Department of Health consent is updated, and we are aware that there is a current current issue with having information released. We are working internally to resolve it, and our care managers are having those DOH consents updated with their members. I don't know if anybody, Kim or Kathy, if you want to add anything to that.
I think you summed it up.
Okay, great.
You did cover it well. Thank you.
Okay, great. So question from Nikki. For the in-person requirement, is this just the care manager and the member who must be face-to-face, or is the expectation that all service providers and team members also need to be in person? Can team members continue to be remoted in via Teams?
Yes, they can. It's the care manager and the member who have to be present in person.
Thanks, Kathy.
Sure.
Question from Thomas. When there is a Medicaid coding issue, like missing exception codes, who should be reaching out to Medicaid, the family or the care manager? That does depend. It depends on whether there's a consent for Medicaid to release that information to the care manager. So sometimes that is a roadblock to being able to help with Medicaid. If there is a Medicaid coding issue, I would advise reaching out to the care manager and making sure that they have permission to speak to Medicaid on behalf of the member if the member needs that assistance. It's absolutely a care manager's responsibility to help their members maintain the correct Medicaid coverage. I can also note that we do have benefit coordinators that support our care management teams in these Medicaid issues as well. So care managers can reach out to them for guidance if they're not sure how to have that code removed. So absolutely contact the care manager and they'd be happy to help you with that. Okay, question from Elisa. This is a follow-up about meetings that are held and the provider is not present. How do we go about consent when we try to obtain the life plan after? So again, you should be listed on that DOH consent form, and that is the care manager's responsibility to make sure you're listed there. If you're not listed, the care manager will have to meet with the member to update that consent form. In the meantime, if you happen to have your own consent form from your organization that is signed by the member and allows us to release information, specifically naming ACA NY or LifePlan CCO, then we'll be able to take that consent. We run it past our compliance department, and then we'll be able to release the information as long as it's HIPAA compliant. I have another question. Do we get to have a copy of the DOH consent? Kim, Kathy? I don't believe, I believe it's usually just kept in the member record, but I don't know if there's a clear answer for that. Yeah.
It's best, for providers just to verify with the care manager, at life plan meetings, can you just double check the consent, make sure that we're listed. The care manager at the annual life plan meeting and at the semi-annual life plan meeting should be bringing a copy of the consent to update, either annually to do a brand new consent or semi-annually to update it. So just to verify that the providers, are included on there at the time of the life plan meeting.
Okay, great. Thanks, Kim. All right, I think we've taken, about 5 to 8 minutes here, so we want to keep the presentation moving. We're going to move on to the next question. I mean, not the next question, the next section of the presentation. Thanks.
Great.
So it's my pleasure. I'm going to introduce Catherine Grice. She's going to discuss the CCO enrollment process.
Okay. Thank you, Megan. Thank you, Crystal. We'll continue today's presentation with an overview of the CCO enrollment process. We'd like to review this process as it's a topic that's regularly raised during our provider meetings. We hope that this information provides insight into the steps involved in enrollment and the common reasons for delays. As you can see, provider agencies, particularly those with family support services, are one of several referral sources for CCOs. It's important for providers to have clear and accurate information to share with prospective members, as the enrollment process can be complex and lengthy. There are multiple steps that must be taken before a prospective member can enroll in a CCO. The enrollment process is highly individualized and varies depending on several factors. This is a general list of the various steps involved when enrolling in a CCO, though they are not necessarily completed in this order. We'll explore these steps in further detail over the next few slides. Prospective members typically start the enrollment process by contacting their regional OPWDD front door team, who completes the eligibility, assessment, and authorization tool, or the EAA. Sometimes a prospective member will reach out directly to the CCO first. In these instances, the CCO enrollment team will help connect them to the front door. The EAA tool helps identify services that will benefit prospective members and is an important part of the person-centered planning process. It's completed at different points in the process, depending on the DDRO for the region in which the prospective member resides. The CCO enrollment staff will help the prospective member apply for OPWDD eligibility if they don't already have it at the time of referral. The eligibility review process can be lengthy and timelines vary by region. All eligibility applications must include a psychological evaluation, a social or developmental history or psychosocial report, and a medical report. Specific criteria must be met for each of these, as shown on the slide. It's important to ensure that the IDD diagnosis is included in the medical report. There may be some flexibility given on a case-by-case basis regarding time limits for evaluations.
Hi, Kathy. I'm just going to stop for 1 second. I think we may have hit a little snag with the PowerPoint. I think we're stuck on the previous slide. So I just want to give that a chance. There we go. Thank you.
There it is.
There we go.
Okay.
All right.
All right, we'll just keep this one up for a second so that people can read through that. So, okay, so the EAA tool helps to identify services that will benefit the prospective member, and it's an important part of the person-centered planning process. It's completed at different points in the process depending on the DDRO for the region. Okay. The next slide. Thank you. The CCO enrollment staff will help the prospective member apply for OPWDD eligibility if they do not already have it at the time of referral. The eligibility review process can be lengthy. Oh, wait. Oh, I'm sorry. Lost my spot here. All eligibility applications must include a psychological eval, a social developmental history or psychosocial report, and a medical report. Specific criteria must be met for each of those shown on the slide. It's important to ensure that the IDD diagnosis is included in the medical report, and there may be some flexibility given on a case-by-case basis regarding time periods for the evaluations. OPWDD may require more information or recommend additional evaluations depending on their prospective member's diagnosis. For example, an autism diagnosis must be accompanied by a specialty diagnostic evaluation, such as the Autism Diagnostic Observation Schedule. Once an eligibility determination is made, the CCO enrollment staff will apply for initial LCED. The documents and criteria we reviewed for the eligibility application are also required for the initial LCED. An initial LCED must be signed by a QIDP, a physician or nurse practitioner, and the DDRO director of the region in which the member resides. The LCED is a document that will follow the member throughout their enrollment in CCO and HCBS waiver services. The care manager must redetermine the LCED once every 365 days. As noted earlier, at both ACA NY and LIFEPlan, LCEDs for all members are now redetermined during the same month and every 11 months thereafter to avoid a lapse. LCEDs are uploaded to choices under supporting documents in the member's record and are attached to the annual LIFEPlan for distribution. There are several additional steps that must be taken before a prospective member can enroll in the CCO. Everyone enrolled in a CCO must have active Medicaid through the local Medicaid district with the appropriate coverage codes for billing. The Medicaid application process can be daunting as it differs for adults and children. We will go further into details about Medicaid requirements on the next slide. A CAS assessment for adults or a CANS assessment for children under 18 is required to enroll in the HCBS waiver. It is conducted by Maximus, who is subcontracted with OPWDD, and is ideally completed before or soon after enrollment into the CCO. We discussed these evaluations in detail at our webinar in February, which is available to view on the provider pages of both the ACA NY and LIFEPlan websites. The CCO enrollment staff will complete the necessary DOH consent forms with the prospective member and their representative. The DOH consent forms demonstrate that the member wants to enroll in the CCO and with whom they'll allow us to share information. Once these steps have been completed, the CCO enrollment staff will submit the CCO1 enrollment into choices. OPWDD processes all CCO enrollments on the first day of the month following submission.
Okay, we're going to move on to Medicaid requirements. I want to take a few minutes. First, I want to say thank you, Kathy, for that overview. We're going to just talk a little bit about Medicaid. I want to take a few minutes just to revisit those requirements because there are differences in the Medicaid requirements for CCO services and HCBS waiver services that are important to understand. Providers often come to us with questions about denied claims. The Medicaid application process is also one of the major reasons for delays in enrollment. All CCO members must have active Medicaid through their local Medicaid district. That would be New York City HRA for those in the 5 boroughs and the local Department of Social Services for all other counties. If the prospective member already has Medicaid when they're referred to the CCO, the enrollment staff will verify that the coverage code itself is correct and that there are no conflicting codes indicating enrollment in another case management or health home program. If the prospective member's Medicaid coverage is through the New York State of Health, they must agree to have their case transferred to their local Medicaid district. This is critical because long-term care and waiver services are not billable through the marketplace. The CCO enrollment staff will assist with transfers as well as any other changes that need to be made to the case. Once enrolled, it is the care manager's responsibility to ensure that members maintain the correct Medicaid coverage for their services. If the prospective member does not have Medicaid, the CCO enrollment staff will help them apply. There are key differences for adults and children that are important to understand as they factor into the length of time it takes to complete enrollment. If a child under age 18 is referred to the CCO without active Medicaid, and they do not qualify for Medicaid based on their parents' income and resources, they can apply through a process called parental deeming. Parental deeming involves applying for the HCBS waiver before Medicaid so parental income can be waived. Children who fall into this category are assigned to a specialized admissions coordinator who will complete the waiver application and submit it to OPWDD. OPWDD then notifies the Medicaid district that parental income should be disregarded via a letter of introduction. Not all children will be able to obtain Medicaid through this process. Sometimes OPWDD will determine that a child is not eligible for HCBS waiver services. If the child's need for services can be met through other sources of funding, those options must be explored first. Other funding sources may include natural or community supports, early intervention, school supports, or family support services. If the child is not approved for HCBS waiver, they can appeal the decision or reapply later after they have exhausted other options. Now that we've reviewed the Medicaid requirements, it's important to note that there can be challenges and delays to CCO enrollment. We touched upon most of these challenges earlier in the presentation, but I want to mention those that come with enrolling members who fall under special populations. Special populations include people being discharged from an ineligible setting to the community or a certified residence. Ineligible settings may include hospitals, nursing homes, rehabilitation facilities, ICFs, developmental centers, and residential schools. It may take substantial time to develop a safe discharge plan or to secure housing for these members, which can cause significant delays. If the prospective member is coming from an institutional setting, the discharging entity must also have their Medicaid case type changed to community coverage. Enrollment cannot be completed until the first of the month following discharge, so it's important to work collaboratively with the discharging entity to help keep the process moving. Both ACA-NY and LIFEPlan CCO have care connection specialists that can assist in resolving enrollment challenges. The specialists can provide linkage to family support services and other systems of care if needed. They can support members leaving an ineligible setting to either a certified setting or to independent living. They can assist with obtaining appointments that are needed for evaluations, such as the psychological or the adaptive behavioral assessment. They can also assist with Medicaid applications and communicate with the Department of Social Services for updates. The specialists also can start the HCBS waiver enrollment process during the CCO enrollment process. Okay. So to contact the Care Connections team, please use the contact information that we have listed on this slide. I also want to note that the questions mailboxes for both organizations will take you to our customer service center should you need to contact them, as we mentioned earlier. Before we move on to discuss service authorization processes, we'd like to give our providers the opportunity to ask any questions they may have about the CCO enrollment process. So I will kick that off. Let me just scroll up.
I think where you left off with Allison's
Sure.
question at 326.
Okay, so there was a question about CDPAP, if that is the responsibility of the care manager to assist. Yes, that's a service that the care manager should be assisting the family with accessing. Okay. Next question from Ed. What if the person simply does not have the reports? Who will assist? So our Care Connection specialists do work with the member to secure those evaluations. We do not perform the evaluations. But we do have, relationships with the Article 16 clinics, so we do try to refer to those. And then if we have other, other sources that we can refer to that, take the person's insurance, will help with that as well if they have outside insurance. Okay. Do care managers need to do the DDP2 evaluation annually or once every 2 years? So I believe that's once every 2 years. Yeah.
It's once every 2 years unless there is a significant change in a person's ability level. It can be done at any point if there's a significant change in their ability level or their medical need.
We have a question from Deanna. The LCED doesn't have to be signed by a doctor. So there were some changes to that requirement for the initial LCED. So that change includes the allowance of nurse practitioners. And for, let me see, I believe it's a nurse practitioner. I know we said this earlier on the slide, and of course I don't have it in front of me.
It's a QIDP, nurse practitioner or doctor, and the DDRO director in which the individual resides.
Okay, thanks, Kathy.
Sure.
All right, yeah, so that was a requirement that that was changed in the last few years. Okay, next question from Allison. For those with initial eligibility who are only receiving one service with the limited exception rule, how can the CCO and the care manager assist the family without the person losing their ability to attend their one respite program? I'm gonna turn that over to Kim and to Kathy because it's been quite some time for myself since I've dealt with a limited exception.
Yeah, the limited exception rule is really difficult, honestly, when pursuing waiver services. In addition to that, it's because of the exception. It's kind of the decision is to either stay with care management or withdraw from care management in order to keep most often the case we see this with respite, to keep the family support respite. Sometimes when, especially with kids, when they're coming to the CCO and they're already participating in respite, and then we work to waiver enroll them. If the waiver is denied, then they must opt to either select and stay with the CCO service or the family support service. They can no longer have both because it won't be funded through the waiver.
Okay, thanks, Kim.
And then we also had one from Deborah about the NOD09. She asks if the NOD09, if the care managers are distributing those to providers, and is there a time frame?
They should be. We're going to touch on that. We're going to touch on that, but not to jump too far ahead. The NOD09, once it's issued to the care manager and the member, should be shared with the provider soon thereafter.
Thanks, Kim. Okay, so Crystal, do you have any more questions on your end that came through?
No, that was
okay.
it.
All right, so let's move on to the next section. Thank you, everyone. Again, if we were not able to get to your question, please put it in the chat box and we will answer it in the Q&A document that will be posted on our website. Now it's my pleasure to introduce Kimberly James to discuss service authorization processes.
Thanks, Megan. We're going to continue our presentation by discussing the Service Amendment Request Form, or the SARF, and the Request for Service Authorization, or the RSA. We want to spend some time reviewing the service authorization process, as the topic often comes up in meetings with providers, and we'll go over the process completing these forms and discuss some of the reasons for delay. When an eligible member would like to receive OPWD waiver services, they must first receive authorization from their local DDRO before the service can be rendered. A service is first authorized when the prospective member applies for the HCBS waiver through the completion of the Request for Service Authorization, or the RSA, as part of the application packet. The care manager will document the OPWD service, the amount of units, and the agency or agencies that agreed to provide the service if known. Before the RSA can be submitted, the care manager will work to obtain a commitment from the provider before submitting the RSA as part of the waiver packet. However, if the care manager is having a difficult time securing a commitment, the form should not be delayed, and the care manager will continue to seek providers for all services the member and/or family has chosen to pursue. So I'd like to take a moment to show what the RSA form looks like. Please note the service type, units being requested, and the service provider agency noted on the form are expected to be completed by the care manager during the preparation for the waiver submission. If at the time of the request, the service provider is not known, that section can be checked off on the form. In addition, the explanation of need for service or the justification also needs to be completed. Having a well-written and thorough justification to explain the needs for the service is an important piece to ensure timely enrollment into the HCBS waiver. Once the front door team receives the completed RSA and waiver application, the materials are reviewed, and if approved, service is authorized. The member and their representative, along with the care manager, will receive that NOD, Notice of Decision 09, showing the approval. The care manager will send a copy of the NOD 09 to the provider. It's important for the care manager to follow up with identified service providers to ensure that necessary enrollment materials are submitted to the DDRO via choices, including the DDP1 and DDP1 supplement when required. Important to note that if a provider starts a member in service before they receive the NOD 09 or before the services are fully authorized, they are at risk of not being paid if the services are not approved or if there are delays in the approval. Next, we'll talk about the service amendment request form. The service amendment request form is completed by the care manager when a change must be made to an enrolled member's waiver services. SARF is only used for the following HCBS waiver services at this time: community rehabilitation, community transition services, DAHAB, family education and training, pathway to employment, pre-voc, respite, self-direction, budget authority, and supported employment. A SARF is completed when there is a request to add a new waiver service, for example, requesting community HAB service for the first time, or to increase or decrease the number of approved units for an existing waiver service. As an example, this might be to decrease the number of days at DAHAB in order to take part in community HAB on alternate days. A SARF is also completed to request a change in service provider for an existing waiver service. So for example, Bobby is attending DAHAB at Agency X and is seeking to change to receive the same DAHAB service at Agency Y. It's important to note that if a member previously had a service authorized via the front door or through a prior approved SARF, a new SARF submission may not be necessary. For example, if a member was authorized for community rehabilitation through the front door, but chose not to immediately enroll in the service, that authorization is still active and can be utilized at a later date. Before submitting a SARF, care managers must verify all existing waiver services currently authorized on the CR4 in choices. If a service was authorized prior to the implementation of the front door in 2013, the only way a care manager will be made aware of this is once the SARF is submitted. The DDRO will provide that information to the care manager and request the SARF to be updated and resubmitted as necessary. This is an example of a SARF for a member who's seeking community rehabilitation services. Note that the NOD 09 is issued in service units, which is the required submission method. We recognize that providers will often share information in billing units, which then the care manager must convert into service units before submitting the SARF. This is a frequent cause for errors and return SARFs, which then need to be corrected and resubmitted. We strive to have the SARF form completed timely and accurately upon initial submission. Once the care manager completes the SARF, it's reviewed by their supervisor prior to submitting. It's recognized that the SARF form can be challenging to complete. OPWD is in process of developing an online modified version of the SARF that's expected to be implemented later this year. And here are some of the more common issues that may delay SARF approvals and require resubmission. If the member's demographics on the form are in conflict with what is reflected in choices, all of the current services are not listed, the services listed do not have the correct units or are mislabeled, billing units versus service units, insufficient justification, there's missing supportive documentation, or there may be delays in submission and resubmission. The member may also be enrolled in services that they no longer use, so it's important that the care manager evaluates with the member, runs the tab's inquiry and choices, and reviews the life plan, as the services they are no longer using must be dropped when the SARF is submitted. After the SARF is submitted, OPWDD will provide an automatic response that it was received. Providers can request that the care manager forward these responses to them to confirm the SARF submission. Generally, OPWDD will respond within 3 weeks with the approval, denial, or request for correction to the SARF. And please note that these timelines may vary by region. If the SARF needs correction, the care management team will work to create a new SARF and resubmit to OPWDD for review. This will then restart the turnaround time to get the approval. At ACA-NY and LifePlan CCO-NY, we are launching an internal training and processes to track and monitor SARFs from submission to approval. We're doing this to ensure timely access to service for our members, and we anticipate this will be available to the care managers beginning this June. When a SARF is approved, OPWD will issue the NOD09 to the member representative and the care manager. The care manager will then update the member's DOH consent form with the new provider's information if necessary. The care manager will then notify the provider and send the NOD09 for their records. A life plan addendum will also then be created for any newly added services following the receipt of the NOD09. As noted earlier, it's important to note that if a provider submits the DDP-1 and delivers services before receiving the NOD09, this may jeopardize billing. The provider will not be reimbursed by Medicaid until the service has been authorized by OPWDD. If a service within the SARF is not approved for any reason, the care manager will work with the member and their representative and the provider to obtain additional justification or determine a more appropriate service if necessary. And this concludes the presentation portion for today's webinar, and we're going to open up the Q&A for questions.
All right, thanks, Kim, so much for that thorough, detailed explanation of the SARF and the RSA. I'm just looking through the questions. We have quite a few coming through right now. I did have one quick question. I think we have a little time going back to that limited liability, the limited exception, and Kim, maybe you can help with that. Just to clarify, with the limited exception, the care manager can help once, and if denied, the family would then need to choose between keeping the respite service or receiving care management. Is that correct?
When they're applying for additional waiver services, yes. So in the case that the waiver is denied, they then have to choose whether, which service to keep.
Okay. And Allison, if you have more questions about that after the forum, we can always email and get into more depth about that. So here's a question, another one from Allison for SEMP. Does the care manager have to request additional units for SEMP or just the initial units? And should units for all services be listed on the life plan?
I just want to break that down, and because it was kind of a two-part question. Yep. So just restate the first part, Megan.
So when doing a SARF for SEMP, does the care manager have to request additional units for SEMP or just the initial units? So it sounds like if somebody already has SEMP in there, yeah.
If they, it depends. If they're looking to change providers and they're carrying the same number of, and they're carrying the same service over to the new provider, I don't believe new additional units would need to be requested. But if it's, someone's adding SEMP for the first time, then the units do need to be requested at the time of the whether it's the RSA or the SARF submission.
Thanks, Kim. Okay, question from Christina. ComHab R and traditional ComHab are, so ComHab residential and traditional ComHab, are those separate SARF approvals, or is a general ComHab approval sufficient for either service? So it sounds like if someone is approved for ComHab, is that general? Can it be applied to traditional ComHab and to residential, or would the residential be a separate approval?
I would want to take that one back just to be sure. Would want to give misinformation.
Okay, so Christina, we'll look into that a little further and we'll answer that in the Q&A document after the webinar. Here's a question from Deborah. Per OPWDD, listing 99999 for SEMP services is okay, but I've been informed from the care manager that this cannot be used. Is this correct?
That can be used, I believe it can be used as a placeholder. Again, I think I would want to get, just clarification just to be 100% sure.
Sure.
That can be used as a placeholder, but there has been communication fairly recently from OPWD that we're really looking to ensure that the units are listed correctly as the units being requested. But my understanding is it can be used as a placeholder as well.
Okay, thanks, Kim. Crystal, any questions on your end?
No questions on my end.
Okay, I don't see any others coming through the chat. So I'll make a last call for questions. If anybody has any. Oh, yes, so here's a question. I did see this pop up before. Is there any way to access old files from Metasched? So I know that we did receive the historical, this is related to our change in electronic healthcare record systems for anybody who's not aware. We changed our EHR last year. So my understanding is that all of the historical data from Medicaid for members who are currently enrolled was received toward the end of 2022, beginning of 2023. And that information is available, but if the member was not enrolled with us at that time, Metasched was not able to release those records to us. I don't know if there's anything else to add there, Kim or Kathy. I don't think so. I think that's, yeah. So if you're looking for documents, if you would like to reach out to the customer service center, they can assist with that. Or if you want to reach out to whichever director of provider relations is in your region, we'd be happy to help you, help guide you there. Let's see. So here's another question from Deborah. What do you recommend for individuals that are off-state contract and were grandfathered in to opt out of care coordination services as they aged? So I think this refers to our legacy cases that, were never waiver enrolled, were never required to have that LCED. I think that's something we probably need to go into a little more depth or even possibly clarify, Deborah, exactly, what the situation is that you're referring to, just because it sounds like it may be more of a member-specific concern. So yeah, so Deborah, we will, if you want to leave your information in the chat, we can reach out to you after and talk some more about that. Okay, here's a question from Allison. This is about listing the units. So once the service is approved, do the units need to be listed on the life plan and for which services? So the answer to that, the services are listed in the life plan, the units. And I believe that's for all waiver services, but I will confirm that. I'll let Kim and Kathy confirm.
I'd have to go back. That's really specific, and it's been a while since I've been in. To be honest, it's been a while since I've been in a life plan to verify that.
Yeah, I would agree with that. We'll come back to you with an answer on that in the written Q&A.
Great, thank you. Okay. So a question from Christina, and this is really related to staffing shortages. We know that providers are all struggling out there for staff. Would it make more sense for the care manager to not list a provider on the SARF? Because if they do and the provider can no longer provide the service, they would then need to submit a new SARF with the new provider name. So I'm going to turn this one over.
Yeah, I mean, generally speaking, trying to and working with coordinating services for our members, it's with the understanding that the provider has the availability to provide, that service. And if they can't, then we would, work to identify an alternative provider, for that reason, because if it's, the service is authorized and we don't have a provider listed, then we have to add a provider, so it just makes a little bit more sense to really try to narrow down and to secure the service in place before completing the SARF. It's a little bit more open-ended, I think, with the RSA, because it's the first service that we're acquiring to be able to open the waiver and to get people onto the waiver. So it's a little bit more customary, I guess, to be able to add somebody using the RSA to get them initially enrolled in the waiver than it would be to take that same route with the SARF.
Okay, thanks, Kim. Okay, here's another one from Christina. Is there a separate SARF approval needed for direct provider services for self-direction, since those are built into the budget? So this would be, if let's say somebody's got direct provider purchased respite, for example, and that goes into their budget, would they need that separate SARF approval for that provider? I want to say that I believe they would, because it does have to be authorized for the provider to be giving that service in the first place. But we'll confirm again in the follow-up document. But since it is directly through a provider, there does need to be some kind of approval. The provider still needs an NOD-09 for that service, even if it's built into the budget. But again, we'll dig into that a little further. Here's a question from Lucia. Will the new SARF submission service coming this year potentially lower the wait time for getting them approved in theory?
That's the idea. That's the idea. I think similarly to how the LCD was transitioned electronically, some of the issues that we see, like with demographic information not matching up, will essentially be eliminated. Things like having a missed digit on a TABS ID or a Medicaid number letter being off, that's part of human error, will really be limited, because that information will come directly from choices as the SARF form is being populated. So that's the idea, is to automate that as much as possible to limit potential human error that might occur when completing it.
Okay, thanks, Kim. Okay, I do not see any other questions. So I'm going to go ahead and say, let's go ahead and wrap it up for the day. Thanks again. If we were not able to get to your question today, or if we needed to expand upon it, we will make sure that goes in the Q&A document, and it will be posted to our website.
Thank you everyone again for joining us today. As noted at the start of the webinar, we will post a recording of today's presentation on the Q&A on both of the ACA-NY and LifePlan websites in the next few days. As a reminder, the directors of provider relations are here and available to assist you with any questions or concerns that you may have. Coverage areas and contact information for each director is available on the provider page of the ACA-NY and LifePlan websites. We also encourage you to utilize our respective customer service centers. We hope to see you at our next provider webinar on June 20th, where we will discuss the incident management and the role of the CCO care manager. As always, we welcome suggestions on topics of future webinars. Thank you and have a nice evening.